Good afternoon, everyone, and welcome to today's webinar discussing diabetes prevention and weight loss interventions for African American populations. I'd like to thank you all on behalf of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, and the Center for Diabetes Translation Research at Washington University, St. Louis, for your participation this afternoon and interest in this topic. During the presentation today, we ask that you pose questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees during the session this afternoon. Today's presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. Today's session will explore the state of the literature on diabetes prevention and weight loss interventions for African American populations. It will also discuss two models of diabetes prevention translation interventions aimed at Black and Latino men and participants receiving services from food banks. My name is Sheldon Oliver Watts, and I'll be your moderator today. I'm the National Director of the Council on Black Health, also known as the Council. The Council is the new identity for the African American Collaborative Obesity Research Network, a collaborative network of scholars and community-based researchers located in over 20 different states. The Council's mission is to develop and promote solutions that achieve healthy Black communities. Our national office is located at Drexel University's Dornsife School of Public Health in Philadelphia, Pennsylvania. The Council leverages the credibility and perspectives of Black American researchers and research partners that positively impact Black communities. I'm also the core manager of the Solutions to Diabetes in Black Americans core at Washington University's Center for Diabetes and Translation Research. As a disparities core, we provide methodological and content expertise to develop innovative approaches that advance the field of diabetes research in Black Americans. Our respected speaker today is Dr. Tiffany Gary-Webb. Dr. Gary-Webb is an associate professor in the Departments of Behavioral and Community Health Sciences and Epidemiology at the University of Pittsburgh Graduate School of Public Health. She has held faculty positions at several other top-tier schools of public health, including the Columbia University Mailman School of Public Health and the Johns Hopkins Bloomberg School of Public Health. Dr. Gary-Webb is an accomplished researcher, having authored and co-authored over 90 scientific publications. Her current research agenda is a culmination of 20 years of experience working to understand the social and environmental determinants of chronic disease and implementing interventions to improve prevention and control. Her research is divided into three defined areas: the social determinants of diabetes and obesity, interventions to improve diabetes outcomes for minority populations, and translation of research findings to practice and real-world evaluation. Dr. Gary-Webb has held leadership positions in several national organizations, including the American Diabetes Association, the American Public Health Association, and the Council on Black Health. She is now, expanding her national and international reach to work on larger structural issues that will affect the nation's progress towards understanding and eliminating health disparities. Dr. Gary-Webb, I invite you to proceed.
Thank you, Sheldon, and thank you to the Council on Black Health for inviting me. I'm very excited to talk a little bit today about some of my intervention work in diabetes translation. So I'd first like to just start briefly with a little background on diabetes. I'm not sure if there are folks on the line who aren't in the field of diabetes, but as you probably know, we have an epidemic of diagnosed diabetes, mostly type 2, that has evolved over the past several decades. If you look at this trend that shows trends in diabetes prevalence from 1950s to the 2000s, you'll see that we had a prevalence of about 1% in the 1950s, and now as high as 8% in the United States as of now. There are market disparities in by race and by sex. This graph shows the ethnic minorities have higher rates of diagnosed diabetes compared with white and non-Hispanic populations. In this talk, I'm focusing on Blacks and Hispanics, and as you can see, there are disparities in both Black men and Black women. So for the most of my career, I have tried to understand the reason for these disparities, and this is a scientific statement that I participated in, which was the first scientific statement from the Endocrine Society evaluating health disparities. And what we did is looked at the state of the literature for all of the causes of, potential causes of endocrine disorders, myself focused on diabetes. And we were able to look at biological, clinical, and non-clinical factors. So for example, using this framework, we can see that there are approximate factors which many people are familiar with that influence diabetes outcomes. So for example, my endocrine colleagues study the biological and genetic pathways such as allostatic load and epigenetics and biological responses to stressors and so forth, and clinical factors. My clinical colleagues and some of my public health colleagues focus too on proximate factors such as individual risk behaviors, smoking, diet, physical activity, and individual demographics and social factors. What I was able to contribute to this statement is looking at some of the intermediate factors. So what about the physical context? So neighborhood environments, things like availability of food in neighborhoods, accessibility of resources for physical activity, impact behaviors that would impact diabetes outcomes, the social context such as social networks and social capital in neighborhoods influence how people feel safe in neighborhoods, get out and walk, and so forth. And then the healthcare context. So in addition to individuals accessing healthcare, the healthcare context, so for example, quality of care and patient-provider relationships severely impact diabetes outcomes as well. So we were able in this scientific statement to talk about the state of the literature for those intermediate factors and some of the social conditions and policies that would influence diabetes outcomes. The American Diabetes Association, after that Endocrine Society statement, followed through with a socio-ecological determinants of prediabetes and type 2 diabetes statement. I am part of the African American Action Council of the American Diabetes Association, and what we did is we put out a paper that said, okay, if you are a clinician or a practitioner, how can you use this statement? What are the actual practical things that you can do in your setting to deal with some of the social determinants of health? And so for my career, I've been focused on combining observational and intervention research to address the common theme of reducing racial and ethnic disparities in diabetes and associated conditions, which would be obesity, cardiovascular disease for urban African Americans. And so for my observational research, I study the social environment, so things like neighborhood, socioeconomic status, satisfaction with care, cultural factors such as cultural eating behaviors, and intervention research. And so I'm going to focus the talk today on the intervention research. Okay, so translation of the diabetes prevention program. So many of you have probably heard of the diabetes prevention program, so I'm going to be very brief with some of the background. But briefly, it's a lifestyle intervention to prevent diabetes. It was a landmark trial, multi-centered across the country. Had a goal of 7% weight loss, 150 minutes per week of exercise, and individual level behavioral counseling. The results of this landmark trial showed that we could reduce the incidence of diabetes by 58% with this lifestyle intervention. And so this was published in 2002, and so efforts to translate this intervention have been ongoing. So that's in the United States. I show this slide to show that in the United States, we had the finding of 58% reduction in diabetes, but across the world, there were also other diabetes prevention programs. So the Finnish study was published around the same time as ours, the King study in China, and the Indian Diabetes Prevention Program, as you can see, all had very effective weight loss and effective reduction in the incidence of type 2 diabetes. And so this model in the United States, across the world, was a promising model that could be translated into many different settings. So at the time, colleagues thought that how can we take this landmark intervention, make it more accessible, more affordable to a larger population. And so they thought about delivering the lifestyle interventions in the YMCAs, and this was one of the first translation models to occur. And what they did is they found people in YMCAs, screened them for prediabetes, and then put them in a lifestyle intervention in a group-based model. So instead of the individual level counseling that was in the original DPP study, the group-based model provided to be a little bit less expensive and cheaper. And in this pilot study, they were able to show that they got significant weight loss, about a 6% weight loss, compared to the 7 to 10% weight loss in the original diabetes prevention program. So this really sparked lots of different translation models. Fast forward to where we are now, we have lots of different translation models in different settings that we can now do review articles and meta-analyses on this topic. This is one example of a meta-analysis. This is looking at the body of literature on translational studies and separating them out by whether the coaches in the group classes were done by medical professionals, by lay community members, or whether there was an electronic mode to the actual interventions. So with the YMCA model, lay health workers and YMCA staff were trained to be the lifestyle coaches. In other studies, I happen to be here at the University of Pittsburgh, where we use the group lifestyle balance, and we use health professionals, so registered dietitians and so forth, to implement the intervention. But this is to say that there are lots of different ways that the study has been translated, and lots of different settings. So YMCAs and churches and primary care settings and so forth. But really, what is the state of the literature in these translation studies for African American communities? And so I was involved in ACORN in developing these two manuscripts, and we put out this expanded research, obesity research paradigm, where we really wanted to think about intervention research, and we really wanted to expand the whole idea that the interventions on eating, physical, and activity are related to energy balance, but all these other processes, so cultural and psychosocial processes, the physical and economic environments that I talked about, historical and social contexts, are all influencers on how people can engage in healthy diet and physical activity behaviors. And so this sparked a review article from ACORN that basically looked at the the state of the evidence for a number of different obesity-related interventions for Black populations. And so one of the articles done by colleague Carmen Samuel Hodge looked at the effectiveness of diabetes prevention programs, and specifically the translation programs that have been conducted among African Americans. So when you think about the original DPP study, when you look at the actual weight loss in the African American participants in the DPP, it was about a 5.8 kilogram weight loss. So that's where you see this line. So we're comparing all of the translation studies that have been done to the effectiveness of the original DPP study for African Americans. And as you can see, even the higher quality studies that have been conducted, and a lot of them have been conducted by members of our group, have not reached the weight loss of the original DPP. So when you think about the literature that's out there, and it's probably time to do another one of these reviews, There were few published studies, so about 7 exclusively done in African Americans, 10 done with mixed samples. The settings were mostly churches, but overall these translation studies for African Americans had about a 2.8 kilogram weight loss compared to about a 5.8 kilogram weight loss in the original DPP. Interventions that targeted support from family and friends and stress, and so those are studies done by a number of people in our group. They show promise. So one of the outcomes of this particular view is that we need more consideration for contextual factors in the interventions. And so that's been the focus of my interest in translating to African Americans, is how can we incorporate some of the physical context, so the family and social networks, the healthcare context, the physical and social environment, how can we incorporate some of these aspects into the original DPP model while keeping the structure of the DPP model the same, because we have an evidence base that it is actually effective. So I'd like to talk today about 2 models that I've been working in disadvantaged populations. They're a little different. The first is Power Up for Health, which was an NIH-funded diabetes translation for men of color in New York City. This is work done while I was a faculty at the Columbia University. And what we did with this study is adapted the actual intervention and the materials for men of color. The second study, which we're actually in the field now, is through Feeding America, which is the national organization that funds food banks across the country. And we're looking at screening people at food pantries and referring them to diabetes prevention. So not necessarily modifying the actual program, but trying to identify a vulnerable population and then get them linked to services. Okay, so first, the Power Up for Health. This was a collaboration between myself, Elizabeth Walker, who is at Albert Einstein School of Medicine, and the New York Academy of Medicine. We all worked together on this, and we started in basically 2012 developing the background, and I'm going to talk a little bit about the phases of developing this intervention, and then some of the outcomes. So as I mentioned, there's been many translation models in different settings, but when you look at that body of literature, so we looked at the body of literature specifically for African Americans, when you look at it by gender, you see that low income and minority communities, and particularly men, enrollment is low. But when men are actually in the studies, they do well in the studies. So the challenge is getting more men into the DPP model. So we tried to pilot test this adaptation focused on men from disadvantaged communities. Okay, so the overview of Power Up for Health is that it's a diabetes translation intervention focused on men of color, Black and Latino. We did not exclude anyone, but we tried to focus on neighborhoods that had predominantly Black and Latino men. It was a 16-based group-based program adapted from the national DPP. So I mentioned there are several CDC-approved translation models. The Y model is one of them. The national DPP model is a combination of a lot of different models. And then our group lifestyle balance is another translation model. So this was the national DPP from CDC. And we were set within parks and recreation sites in New York City. So recognizing that when you're in New York City, that people don't have a lot of green space. So they take advantage of the city parks. And so a lot of the parks have recreation centers that have pools and fitness centers and fitness classes. And we thought, what a great setting that could potentially be sustainable if we did the DPP in those settings, and then staff within those recreation centers could take over the programming. Recognizing that we knew we needed more expertise to try to recruit men, we also had an advisory board with academic and community partners and people that focus specifically on men. Okay, so as I mentioned, we had several phases. So we started out when we had the idea doing focus groups with our target population. So we did one with African Americans and one with Latino males, and just talk to them about the program. So if we wanted to do this program, what are the types of things that we should consider? And these are some of the recommendations to think about the cost benefit of attendance. So if men are going to come to a class weekly and spend time, away from families, time that they could be working, that the program really needed to be worth it, that we needed to have incentives that appeal to men. We need to incorporate concepts such as sports. That was a resounding theme, incorporate those types of concepts. And then also recognize that this model of, kind of support group model could be difficult for men because you have to share, some weaknesses and talk about different difficult things. And so some men may have some difficulty with that. In phase 2, we convened our advisory board, and this was a 10-member advisory board with lots of people with expertise in men's health, and not just in New York City, some scholars from Atlanta, from Philadelphia, from other places. So we really tried to identify people who were strong in that area. And we convened them twice per year, basically to discuss the exercises. So as I mentioned, we could not change the structure of the DPP. But what we did want to do is update some of the examples, because some of the examples were heavily focused on women, and in particular middle-class women. So we worked with the Advisory Council to do that, to update our graphics. Fortunately, New York Academy of Medicine has a graphics design department inside, and they were able to do our graphics. And then we also went to our advisory board about recruitment strategies. Okay, so this is just an example of our first session, and we have men, middle-aged and older men who are the target population for this intervention. We tried to have a diverse group of men, considering that we were in New York City. For each of the 16 topics, we changed all the graphics. So these are just a couple of examples. Session 8 is about taking charge of what's around you. And you can see, so New York City, you have lots of food carts, so that's something that you would have to navigate on a daily basis. Excuse me, Session 10, the 4 keys to healthy eating out. We knew that eating out, particularly in New York City and particularly for men, was going to be a major focus of the intervention. So we have some graphics and different examples there. And then the quick facts. So anyone who's familiar with the curriculum, there are quick facts throughout the curriculum. We changed all of them to be focused on male issues and changed some of the graphics. So for example, this one is talking about the prevalence of obesity in men. Okay, so coach training was something that was also a little difficult. So I don't know if I mentioned that the groups, we decided to have all male groups and all male coaches. So finding male coaches who were trained in the NDPP curriculum was very difficult. So what we had to do, we could not find one in New York City. So what we had to do is identify fitness facilitators from the park and recreation centers and then train them. So we sent them to the 2-day training on the NDPP curriculum, and then we had our own training on our actual curriculum. And so the coaches' backgrounds varied because of this. So some of them were teaching fitness classes. We had a personal trainer. We did our pilot testing in phases. So one participant who was in the first group wanted to be trained as a coach for the next group, next cohort of groups. So the roles varied for the coaches. And so how do we adapt it? So we kept the core structure. We changed the examples. We had male coaches. We had materials that would be suitable, t-shirts, pedometers. water bottles, so forth. We wanted to incorporate some friendly competition into the program, but we weren't able to get the numbers to do that. We wanted to have like buddy systems, and so they would work outside of class or, work together. And then exploring a role for significant others was a very controversial thing throughout the study. So our advisory committee, I don't think ever really came to a consensus on this. Some members felt that we needed to have wives and mothers, significant others involved, particularly if we're talking about shopping and cooking and so forth, and that they were such an instrumental part of the men's lives that they needed to be a part of the program. Others felt that the men needed a safe space and, to talk with other men and be able to empower themselves to make some of these changes. So in the end, we ended up not including the women, but we thought for a model moving forward, we may include one session with significant others, or a social event with significant others to include them. Okay, and so finally, I just want to talk a little bit about our pilot testing. So we did 5 different groups. So if, many of you know that the groups are about, between 8 to 15 people. If you're lucky, that's what we were targeted for. So we had 5 different groups, 2 in Harlem, 2 in the South Bronx, and 1 in Brooklyn between 2015 and 2016. One of the South Bronx groups was Spanish language only. We really tried to recruit around those recreation centers. So we put out flyers, we did social media and newspapers. We went to some of the neighborhood clinics, and they identified patients at risk and then sent them information about the program. And then one of the things that seemed to be most fruitful was doing a blast mailing to public housing around the recreation centers. So we were able to get addresses of any household that had a male, no names or anything, greater than 18, and then we could send them information about the program. We did get a lot of calls that way. Some of the calls were from wives who actually wanted to enroll their husbands in the program. Okay, so in the end, we were able to screen 47 people. We had 2 cohorts. So in the first cohort, we had 2 classes. In the second cohort, we had 3 classes. Remember, these go over 16 weeks. So it took between 2015 and 2016 to get all 5 cohorts through the 16-week session. So if you look at in the end, who was left after the CDC criteria of attending at least 4 classes, we had about 25 people, mostly men, mostly white, Hispanic and Black, and that was our target. If you focus on this last column here, these are the participants that we're really focused on. We had about a mean age of 51 and a mean BMI of about 35. When you look at attendance, the attendance was very good. So as I mentioned, you have to attend at least 4 sessions to be considered active. But we had most of our participants across different sites attend 9 to 16 sessions. So just so you'll get an idea, this is our Harlem site, South Bronx, Harlem, and Brooklyn. Okay, and then the mean weight losses were pretty well. We had, overall, we had a total of a 3.8% baseline weight loss, not as high as we would want it, but 5% weight loss would be a goal to have for the translation studies. And we had 3 of our groups achieve at least a 5% weight loss. We also had significant lifestyle changes, so very improvement in physical activity, pre-post, improvements in doing specific activities, pre-post, eating at least 5 or more fruits and vegetables, and declines in eating high-fat foods. All of these are significant. So we saw pretty decent outcomes, quantitative outcomes. We wanted to get some feedback from the men about the program. So after each of the cohorts were finished, we had a focus group and phone interviews to ask participants about the program. 14 participants participated in this piece of it. And here are some of the things that we wanted to know. So the male-only aspect of the project. So what did you think about that? What were the benefits or downsides of that? Overall, what do you think of the program? How helpful were the program materials, and could you relate to the examples that were provided? And then overall, how have your eating or exercise habits changed? Okay, so given time, I have summarized 4 different findings from the qualitative part, and then give one quote, just because I want to be able to talk to you a little bit about the other project. So men felt like there was no need for posturing. This is related to the all-male concept. So they had increased comfort in discussing body image, eating, and weight loss issues. They explained that they could discuss topics that they wouldn't be able to discuss with the same ease if it were a mixed gender group. And they felt less of a need to filter comments. So this is what one Latino participant said. Since we're men, we have more confidence with one another in venting and saying what we feel and what's happening to us. If women were there, many men act as machos and they feel they can't say what they really feel because a woman is present. The second finding is a camaraderie. So they really felt camaraderie between the participants and motivation to attend class and make positive changes. So one African-American participant said it was more like a powwow, like we're all at the same level, we're just men at a barbershop meeting. Okay, and the third finding is about the racial makeup of the group. So recognizing that it was predominantly Black and Latino, and we did have other races involved, but in very small numbers. How did the participants feel about their racial makeup, and then how did they feel about the coaches? So I should mention that our 3 coaches were African American. One of them was actually Black Latino, so he was the one that conducted the Spanish language. So they were all Black. I think we had sometimes had a hard time relating with some of the examples. So that's where the coach was good, because the coach will bring it to our taste, especially for Black people, for African Americans. Like, this is the thing we eat, these are the kinds of foods, and yeah, so the coach was good at that, at making it more relatable to us, and he was also the same age. So it just speaks to the importance of the men connecting with the coach. Okay, and the last finding were some of the challenges. So some of the challenges were inconsistent attendance among some of the men, which made it hard to build connections. And then the other challenges are not being fully control of their food environment. So as I mentioned before, some of the men weren't primary shoppers or primary cooks for the family, so that made changing behaviors at home difficult. So for example, one Latino participant said, in the beginning, because my mother-in-law is always cooking, she was getting upset because I told her I couldn't eat so much, that I didn't want to. So she thought that I didn't want to eat her food. But that wasn't it. I was explaining to her that in order for her to understand, it was a problem. Oh my God, it was a big problem. Okay, so, lessons learned from this pilot. Recruitment was low despite efforts to link with community organizations, barbershops, and churches. I've had conversations with some of my ACORN colleagues about the difficulties in recruiting men. We had competition with other New York City DPP programs, including the Y program. So that was probably the biggest challenge of this. this particular pilot. In the middle of the pilot, the CDC changed the curriculum. That's less of an issue because CDC still allowed everyone to use the NDPP curriculum, but just wanted to mention it. The tracking of physical activity and diet was challenging. So this is I think a recurring theme with weight loss interventions. So the men were given the option of doing paper tracking or using apps such as MyFitnessPal, but of course the daily tracking was the challenge. And then the park and recreation centers were underutilized. So as part of the project, we gave the incentive of a 6-month membership to the parks and recreation centers, which is relatively inexpensive. It's about $75 for a 6-month membership. And we really thought that would be an incentive for the men to exercise outside of class or either exercise right before class. But that wasn't the case. The men gave some of the feedback that, you know, they didn't like the facilities, that they weren't updated and so forth. So that didn't end up being as good of a setting as we thought it would. Okay, so conclusions. Participants really liked the program. Recruitment was challenging, but the people that we got had really good weight outcomes, and so that's been encouraging. If you're interested in learning more about this, we published 3 manuscripts in American Journal of Men's Health, July 18 of last year. So we have one that's all about the design and development of the intervention, one that's on the outcomes, and then one that's on the qualitative assessment and focus groups. And so the New York City group is now planning to do a larger scale approach in New York City. I've now moved to Pittsburgh, and so I'm not involved in that particular study, but I am looking for opportunities to kind of do this model in the Pittsburgh area. I think although Pittsburgh has lower numbers of Black and Latino men, I do think that there are very strong networks of men, and that if I could identify those networks, that an intervention like this could be very successful. Okay, so moving on to the Feeding America Diabetes Prevention Pilot. As I mentioned, this is not a adaptation of the DPP, but it is trying to identify participants in food-based settings and then refer them to diabetes prevention. And the premise of this intervention is the relationship between food insecurity and health. So food insecurity is the lack of access to adequate food for an active, healthy life. And so 11.8% of U.S. households face food insecurity, and it's considered to be one of those social determinants of health that's correlated with a lot of health outcomes. For example, increased healthcare costs and worse outcomes for patients with diabetes. I'll talk a little bit more about that in a minute. And so Feeding America is the nation's largest hunger relief organization. They fund a network of 200 food bank members across the country. They are now interested in getting into the space of trying to create health-related programming. And so this is a result of one of the pilot projects that they are actually funding. So given that there has been observational research on food insecurity and health outcomes, so what we know is that food insecurity is associated with poor dietary intake, which makes sense, with poor physical, psychological, and behavioral health, and then poor disease management. So that's from an observational point. But what we think we know, and that's why we're testing it, is that if you improve food insecurity, that you could have better diet, lower weight, improve disease management, and have better health. So this is a model coming out of the Feeding America. So it's food insecurity and chronic disease, and using the case of diabetes. So it's basically saying that if you have cycles of food inadequacy, that influences your ability to manage your condition. So this is in the case of diabetes. You also have competing demands. So you may have to choose between healthier foods and medicine and so forth. So this food insecurity cycle influences diabetes control. What we normally do as a traditional clinic intervention is at the time somebody has poor diabetes control, that's where we intervene. I myself have done some of these interventions. Or we wait until people are in the hospital and then we intervene while they're in the hospital. And we know that this cycle, they just keep getting worse. What we're trying to do with this pilot study is, what if we intervene on food insecurity in the beginning? So before people get into this cycle. And so we have this opportunity to address issues at the food distribution site. So when people are at food pantries, we can provide them with healthy food, we can offer nutrition and health education, we can host screenings, and we can link them to resources. So Feeding America did a pilot. Actually, they did a pilot intervention and then a larger scale intervention to look at food insecurity and diabetes management. Those are published studies if you're interested. One is in Health Affairs 2015 and one published last year in AJPH. So now they were interested in testing that same model for diabetes prevention. And so the question is, how can food banks support adults at high risk for diabetes through giving healthy food, supplemental food, making referrals to healthcare and community-based diabetes prevention? So this is what our intervention is actually doing. So I'm summarizing because I don't have much time to talk about this project in full, but it's a collaboration between the Alameda County Food Bank in Oakland, California. So in this study, we have a predominantly Hispanic population. Feeding America and Pitt Public Health were the evaluators on the project. And so we using tablets, volunteers at the food bank screened participants with a CDC prediabetes risk test and enrolled them in the program. If they were interested in the program, they get monthly food distribution, so food boxes with non-perishable whole grains, fruits and vegetables, and so forth. They have the option to get educational text messaging on physical activity and nutrition. If they're not connected to a primary care physician, they get referred, and then they have the option to be referred to diabetes prevention. So this is a flow chart of where we are now. In this study, we had no problem with recruitment. We had a goal of 250, and we reached that probably within a couple of months. We screened 400 people, 257 were eligible, and then out of that 257, 248 enrolled in the program. All of them got the food distributions. 209 wanted the additional text message, educational text messages, and then 113 said they wanted the DPP classes. Okay, so we are in the middle of implementation. We are using the REAIM framework to evaluate the intervention. I'll show you a couple of the components. Reach, we were able to really reach a diverse, vulnerable population. So it was about 76% Hispanic, 8% white. We could have reached more. There was a large Chinese population, but we weren't able to accommodate language concerns. Population, 86% people less than 40,000, making less than $40,000 per year. Very high risk. So 71% of those screened had a high risk, an elevated risk score on the CDC risk test. And of those people, 83% completed. When you're looking at sociodemographic characteristics, you see lower education, some people employed full or part-time. And when you look at food insecurity status, which makes sense because we're talking about the setting of the food pantry, you have about 68% who have identified as being food insecure. When you look at some of the health-related factors, you see most of the participants are overweight or obese and report fair, poor health. We were surprised, and they say it's a reflection of the area and the outreach in the area, that 91% of participants did have some healthcare coverage and were connected to a healthcare setting. The other remaining people who were not, we were able to refer them to healthcare. But a very low percentage of people enrolled in SNAP, only 33%. Okay, and so just a few more minutes. This is a picture from our site visit. We went out to one of the food pantries that is located at a school, which has a lot of traffic because they do it during pickup and drop off. This is a mobile van from the food bank. As you can see on this side, there's eggs, bread, shelf-stable milk. On the other side is produce. So as our participants in the program are going to this distribution already, we give them the extra food box, which looks a little something like this. So they go home with their food box and their produce and their perishable items. So far, adoption has been very well. We have 15 project locations throughout the Oakland area. We use Care Message, the text messaging platform, to do reminders as well as to do educational messaging. The staff and volunteers for the food bank help run this project. They liked using the tablets. They say that one of their challenges is language barriers. So we decided to use English and Spanish to outreach, but a lot of the volunteers do not speak Spanish, so that's one of the challenges. Okay, and then implementation has been pretty good. As I mentioned, the different sites have different pickup rates. So for example, at the school site, there's a lot of traffic, but some of the other sites, we may not have as much, foot traffic and people picking up their boxes as we should. I think the biggest challenge in this project was the existing infrastructure for DPP. So when we went in for the application, the YMCA said they would be our partner and that they could do the classes for us. And two YMCAs out in that area merged. They could not do the classes for us, so we had to find other vendors. We ended up with Solera Health, who is just starting to get into the business because of the Medicare reimbursement for DPP. So we didn't end up getting our first class in until 11 months into the project. And so by that time, some of the people who were interested were no longer interested, or they didn't want to travel to one site or so forth. So it was a little bit of a lost opportunity to not have the classes right away when people enrolled. But nonetheless, the participants are still in classes right now. Okay, so with this particular project, we see that the need and the interest is very high. We had challenges implementing DPP, but we know that the infrastructure now with federal reimbursement for DPP is going to get better around the country. So we're really confident that this model can work in a lot of different settings. And so, the question we can talk about, or we can talk about anything you want, is how can we take this model and how can it adapt? How can we make sure that we have the classes and the referral network to continue this community clinic linkage model? Because I do think that Feeding America is going to be very interested in doing a larger scale project on this in the future. Thank you very much for listening, and I know it was a whirlwind, but I hope to be able to have a little bit of discussion.
Thank you so much, Dr. Gary-Webb. That was a very interesting presentation. I'd now like to open the floor to invite our participants to post questions using the Q&A button in the Zoom webinar interface. And I think we do have a couple of questions, so I'll go ahead and post those. The first question is, what is the literature on interventions targeting minority adolescents in public schools to prevent diabetes? especially with the increased rates of diabetes prevalence, and worse outcomes in minority youth with diabetes?
This is a hard question. I tend to focus, my work doesn't focus as much on youth and adolescents. I focus on middle age and older adults. And so that's really where the diabetes prevention efforts lie. So, there are probably other people on the call and other members of the network who can talk about the intervention specifically for, adolescents and youth. But when you think about the prevalence of diabetes, before the age of 44, we don't have high rates of diabetes, under the age of 44. So really, when we're thinking about population-based approaches and scaling this intervention, which is really where my focus is, we have to focus on that kind of middle age and older adult population.
Certainly, and I think we can kind of share this type of a question across our network and provide further feedback on this just as well.
Yeah,
so
it's a great idea.
Question, and that question is, have you looked at interventions in minority populations residing in rural settings?
This is another area that people have worked in. I have not, because I have lived and worked in predominantly urban settings. But just to say that the rural settings have very, the same type of issues with food access, and even worse, and with healthcare access. Because when you talk about, at least in urban settings, the distance to a healthcare setting or to food resources is a lot closer. So there are lots of access issues in rural areas, and it's an area that needs a lot of research.
Okay, so this question is related to your DPP adaptation trial in men. And the question is, did men share what made the self-monitoring challenging, particularly when using the app?
Yeah, so there was nothing really specific. One thing I will say about the monitoring is the men found the nutrition monitoring to be the most surprising, and they did not know a lot about that information. So prior to the program, they focused more on physical activity issues. And so the whole idea of tracking and monitoring food and understanding really how many calories and how much fat are in certain foods was a surprising finding. So that's something that I think could use a little bit more research in men, is how can we make tracking easier? And using the app, I think most of our men did choose to use the app versus the paper, but this is just something that's a problem across all interventions, that monitoring is hard.
Yeah, that tracking.
And so to do it, to do it for a couple of days or a week, but to do it for months is really difficult.
And did you all offer any incentive for that type of tracking, for bringing back those guides filled out or using the app?
Yeah, so the incentive was only for the research survey. Okay. So they don't get incentives for actually participating in the intervention, because they're actually getting benefit from the intervention. So not specifically for the tracking, but for the surveys where we were looking at outcomes.
Okay. And just a follow-up question to that was there any specific guide used in the process of forming the adaptations for the DPP trial for men?
So I'm not sure I understand exactly what that means, but the way we did the adaptations was in collaboration with the advisory council. So I'll just say a little bit more about how we did it. So we went through session by session, and we looked at each example. We looked at first whether it was relevant, if it could stay, if it was an example that could stay and that was relevant to our population. If not, the Elizabeth Walker, who is a diabetes educator and a strong researcher in the field of diabetes, she was the one that really took the first crack at adapting. Then we would all kind of chime in. And then what we did is we took, I'd say, 3 or 4 of the sessions, and we discussed those with our advisory council. So I'll just give you one example of the changes we made. So the problem solving section was, the scenario was about, I think, Sarah, who had a disagreement with her boss at work and skipped lunch, and then she came home and the first thing she ate was cookies. And so we didn't think that that was really relevant for our population, so we worked to change that scenario. And in the end, it ended up being someone who had a stressful commute and wasn't able to eat, and then, you know, did some snacking later on. So that's just one example of the type of examples that we changed, but there were a lot of them that we had to deal with.
Okay. And I know we're running short on time, but we have a few more interesting questions that I'd just like to have on record. So the first was, could you see either of these program models working for women with a history of gestational diabetes? How would you suggest these models be adapted for them, more specifically minority women in low-income settings with a history of gestational diabetes?
Yeah, so I mean, I think that, yeah, both models could work. I mean, there are people working in, I don't know if it's prevention efforts, but definitely, you know, well, prevention efforts after pregnancy. There are people working in that area. So I think an adaptation specifically in that area could definitely be warranted. As far as the second model in that population, I guess the challenge would be how to find those women who were at high risk. Unless the intervention was conducted right after birth, when the woman comes in for a 6-month visit, it'd probably be hard to identify and screen those, you know, those women, to be able to get enough women with prior gestational diabetes to be in the study, because it is a pretty rare event. But yeah, we're working on a study right now where we're actually looking at weight loss postpartum, and we're using cell phones to be able to monitor those women, because we know after that 6-week visit, they don't have a lot of other contact with the healthcare system. So by us monitoring their weight through electronic modes, we can at least see what the patterns are over that period, like that first year period after pregnancy.
And I could definitely see if this was done with clinical partners, you could have that referral piece to kind of catch these women probably early enough in their pregnancy where this type of behavioral change might be beneficial.
Yeah.
Right. So we have one more question. We'll close with this question. And it has anyone addressed the effects of these interventions on family relationships and food culture? And I know one of the men in your DPP adaptation study had talked about some of the issues with the household and some of the complications with the changes in their eating. But could you run a separate set of classes for household food preparers?
Yeah, and I think definitely because it kept coming up and it was something that we did not address, I think definitely in the next model, we want to try to make a place for family and significant others. So the model that I'm trying to, you know, develop here in Pittsburgh, we would definitely either want to do one session for the significant others, or try to find different sessions that are relevant. So particularly in the beginning of the program where there's more focus on food, maybe engaging the significant others in earlier. There have been other studies. Our founder, Dr. Kumanika, has the SHARE study where she looked at family and friends. That's something that you could probably look up, that model. That study was actually included in that DPP translation review article that was done by Carmen Samuel Hodge. So if you're interested, look up that study.
Sure. And maybe we can follow up with some of those references that you included in your presentation, as well as some that might support some of the work that was presented here today.
Yep, wonderful.
Yes. So I'd like to thank you, Dr. Gary-Webb, for your time. And I'd like to thank all of you who participated today in the Solutions to Diabetes in Black Americans webinar, Diabetes Prevention Translation Interventions for Disadvantaged Populations. We will share an evaluation survey and video of this webinar shortly. And again, thank you for your attention, thank you for your interest, and have a pleasant and safe afternoon.